It is 5:30 PM, Wednesday, September 19th, 2018. We are meeting for a special board meeting in the administration building the boardroom of the administration building at 2000 North 23rd Street in McAllen. At this meeting, there may be discussion by the board on the items listed below. And the first item would be report regarding employee benefits plans. And this time I'll turn it over to Dr. Gonzalez.
Yes, sir. At this point, I will turn the floor over to Mr. Todd Miller and Mr. Andy Silva. Mr. Miller?
Good evening.
Hello, Mr. Miller.
Mr. Roger Garza from Valley Risk Consulting will be discussing tonight an overview of our self-funded employee benefit plan and the district's proposed 2-year strategic plan for its medical group benefits. It's important to note that some of the items included in the strategic plan still require some action from the district and/or consultant prior to actual implementation. Mr. Andy Silva, Director of Employee Benefits Risk Management, is also available to answer questions, as is Mr. Javier Liao. Good evening, Mr. Garza. Go ahead and proceed, please. Roger, can you hear us?
Ready?
Yes, sir.
Yes, I can hear you.
Go ahead, sir.
First of all, good evening, everyone. If you turn the page on slide number 2, what we're going to do is give you a briefing on what we've probably already seen. We did a presentation earlier this year providing some of these numbers. If you notice, you're currently running approximately at $584.61 in medical costs per employee per month. It's reduced slightly, but not very much from our projections. But it is slightly a little bit better. Next slide, please. On slide number 3, you'll see currently what the fund balance, the current fund balance. You see the 2017-2018 transfers in of $541,699. We're looking at projected revenues of $23,156,086 and expenses of approximately $22,779,007. We have a projected fund balance of $5,020,411. These are projected numbers. These are not hard dollars.
Roger, if I may interrupt, Roger? Yeah,
Yes.
This page is what's in our general ledger as of June 30th. It is unaudited, so obviously we're still going through our audit, but this is how the plan performed for the July 2017 to June 2018.
I just want to back up. I have a quick question on page number 2, under medical utilization for October 27th. We're, $500,000 for medical utilization, which is significantly lower than any other month. Is there something that happened that month, or is just didn't have that many claims that month?
No, there's actually something, and you can see that it kind of stabilizes in November.
Right.
What happened is understanding there was actually a time where the system had to be shut down. There were doing some updates in the system, so claims
Okay.
actually didn't get paid.
Okay.
So they all hit the next month.
Okay.
So that was the explanation that was shared with us.
Okay.
Go ahead, Roger.
One other
I'm sorry.
question. I'm sorry. I'm trying to digest this employee per month. 584. It says PMP, and that I understand stands for employee per month, right? This is also.
That is the average cost.
Okay, is that also taking effect if you have an employee and they have their family in there? Are we classifying the dependents as employee per month, or does it fall under?
Yes, Mr. Alvarado, in some of the carriers will break them down per employee or per dependents, or we call them per belly buttons. And we would like to just focus on the cost per employee per month combined.
Okay, so it encompasses,
That way it doesn't spread it out.
one employee can, their cost could be a lot higher due to maybe their family member or family of four as opposed to someone who's by themselves.
That is
Okay.
correct.
Okay, that helps me. Thank you.
If we go to the next slide, slide number 4. Currently, we're at 585. We're projecting a 2018 at 614, which we're very close. In 2019, we're projecting approximately 645. Again, this is per employee per month. If we go to slide number 5, next slide, please. This slide will give you an indication of how you're doing in comparisons to other school districts. Taking from left to right, you'll see that from Harlingen through PSJA, Edinburgh, and these are current, so if there's any changes coming up, we haven't heard of them yet, but this is the current cost.
Mr. Garza, I have a question about this.
Yes,
Now, this is what the district contribution is, but it doesn't mean that, let's say, for example, PSA, they don't exactly have the same cost or benefits that we do. Am I correct?
can you qualify that question, please?
Sure. So just because they're contributing more doesn't mean that their plan is better than what we currently have for our employees, right? I mean, do our employees,
It's not better, it's just spending more.
right? So again, just because they're contributing more doesn't mean that the employees from, let's say, that neighboring district, doesn't mean that their benefits are better than ours.
No,
Okay,
no.
just,
It's just that the cost is higher.
so they're having to contribute
There's
more.
some school districts that don't absorb more costs,
Okay,
but at some point they're going to hit that, the breakover point where they can no longer afford it.
So, I'm sorry. So Sharyland is at $352. The district contributes that to their plan per employee. What this doesn't reflect though, is, for example, if my family is under the plan, or let's say I'm under my wife, who's a teacher with McAllen ISD.
Okay.
Does Sharyland and other districts impose a cost because I'm under that plan? In other words, are they paying higher because they're bringing their family over? So if, for example, where I work at, if I bring my wife to my plan, I'm paying an extra $100 a month because she has an eligible plan at her work. So, you know, the incentive is to keep her in her and not bring her over to mine. Are we kind of doing the same thing? And I apologize, just for the record, I haven't been to these meetings because in the past I've had a little bit of my work tied into insurance. It's not, so I have no conflict, so I'm just trying to get back up to speed on a couple of these things. So do we have the same thing in here? Where, you know, maybe I'm jumping way ahead, so.
Good question. It's a good question.
Well, it's a good question, but we don't penalize employees who bring their spouses onto the health plan when they have available coverage where they're at. But in the case of most school districts, the spousal rate is almost equal to the cost of the employee rate, so therefore, if they're already having benefits where they work at, they'll typically stay there.
Well, it depends. I mean, someone like myself that, where I'm at with my employer, my contribution is really high before I had to pay $2,500 just to, you know, out of pocket. So I'd rather switch go under my wife's. But because of, you know, there's no incentive, I probably will do that next year, just to be quite frank with you. But I think we got to prevent that. I should be able to stay with my plan, because then our costs are going higher and higher every year.
Well, and Mr. Garza, I'm gonna try and address some of that. So to answer your question, no, we don't have a surcharge or penalty for when a dependent spouse is eligible in another plan. But to address that, it's one of the things in the strategic plan is that our family and dependent plans are definitely not funded appropriately.
Okay,
And so one of the things you're gonna be hearing about today is
awesome.
what needs to be done to fund them appropriately.
Okay,
So,
I'm jumping way ahead,
no,
so
that's fine.
thank you.
Yeah,
Andy,
but that's good, it's a good question.
Andy, how would you track the, like what he's saying, how would his,
Yeah.
just ask them if
Yeah,
they're available?
there would be a process where, and we've seen it from other employers, they'll come to us and say, we have to sign a document that says we either offer a spouse coverage, yes or no, and if so, how much does it cost? So
So
it
it's
would
not
be
just a
some
matter
kind
of asking the employee.
some
you
kind of
verify
form
the
that we
employee.
provide to the spouse. Say, please
But
sign
also,
it.
when you go to a doctor's office, certain providers,
They require you
they're
to
required to fill out a
disclose
secondary,
these other-
and then that information should come back to you. Because as our insured carriers should want that information, because they don't want to carry me. You know, so I think there's ways for us to get that information. And again, I'm not trying to penalize anyone, just trying to be fair, you know, to help the district since we're
Well-
self-funded.
But you make a valid point. If the law states that employers are responsible for the cost of coverage for their employees. So if you have a spouse that has a job at let's say ABC's,
Sure,
company, and the cost is too high for her, they normally will incentivize her to come over back to you. So there's a lot of manipulation in the industry right now. So if you identify an employee that has a spouse that's working someplace else, and the employer is not providing that coverage, then there should be a penalty, if you will, for her to participate in your plan. Or her, he, or it doesn't matter.
okay.
Mr. President, for me, is there any way we can use a different term than penalty? I mean, what's the statute say is the term?
I think the term is surcharge.
It's a
That's what
I'm gonna call it surcharge.
Okay,
Surcharge.
yeah, that's what I understood it to be, surcharge, so I just want to be clear that it's, and maybe we should just stay to the
But-
language. I understand what everybody's saying, but it has a different connotation that if we use a term like that, that's not part of the statute. Go ahead, sorry.
If you wait just to the strategic plan, you'll see where we identify that.
Okay.
So if we move to the next slide, slide number 6, please. You'll see the TASB survey that we presented a few months back. Those show the average district contribution per employee only. Those show the average contribution per employee cost. Those show the average employee contribution per employee plus family. And McAllen ISD is way below those averages.
So that sort of speaks to your comment, Mr. Alvarado,
Yes, sir.
that in our plans currently, it's probably more attractive to come into our plan
No doubt.
than it is to stay
Anywhere else?
at a competing.
Yes.
So again, that's one of the things that, one of the challenges was, okay, well, how do we address that?
Right.
So one of the strategies in here is to target the plans that ultimately are incurring the greatest cost and have the loss ratios that are way out of line.
Because if not, the costs keep going higher and higher, then everyone is gonna have to share the burden, you know, and I guess the rationale for that surcharge and if you do decide to come over, then you should pay more than someone who doesn't have a family over. So I get it, okay.
Next slide, please. This slide will show a comparable of Region One school districts. It gives you an idea of exactly what, or where McAllen ISD stands at in comparison to other school districts. And we'll find yourselves very competitive in terms of cost and funding. Now, not all plans are identical, so we got as close as we could, but
Mr. President, again,
Yes, sir.
thank you. Roger, Mr. Garza,
yes, sir.
do we know what the fund balance is for these other school districts and their medical program?
As a matter of fact, I can tell you that there's only 2 school districts in this ledger here that are showing a black fund balance. It's the one on the right and the one on the left.
Talking about the middle column?
I'm talking about, there's 3 of them, one on the left. But your school district has a positive
These
fund
two, right?
balance.
Okay. I
And
didn't want
the
to say
one
it
on
out
the
loud.
right, the Naaman School District has a positive fund balance.
Do we know by how much?
In terms of size, you're very close to comparisons.
To what McAllen has right now in the fund balance?
In fact, I beg your pardon?
To understand, we have a $5 million fund balance. Are you saying they're comparable to our amount of fund balance, or?
In terms of size, they're at approximately 2.8, almost 503 million.
Okay. Thank you.
Yes, sir. The school districts below that have had to increase funding the last 5 years.
Got it. So I mean, they're going to be in the same boat we are. If not already, they're gonna- they're
Next
already-
slide, please. Well, this is what we're looking at in 2018 and 2019. Assuming if you look at the heading, it's assuming no rate changes. The current employee contribution, including the dental contribution, is approximately $22,862,304. We've done a general fund transfer of $1.5 million. We're anticipating $300,000 of pharmacy rebates. So our total 2018, 2019 contribution is $24,662,304. Our total projected expenses are $24,456,161. Cost of our contributions is $206,143.
See your contribution over cost?
In simple terms, it appears to be good news. In a actuary standpoint, it's not good news. You're basically paying for expenses as you go, but in the insurance world, you would need approximately a 20% buffer of revenue over expenses to consider a positive plan year. Assuming that the nothing is done this plan year, you would have a fund balance of approximately $5,226,554. And again, that's not hard dollars, that's just soft dollars.
Mr. Garza,
Yes, sir.
if the projection is that we're gonna have $5 million in our fund balance, why would we need to contribute $1.5 million? It kind of looks like if we're just padding the overall number.
Is that projection?
Well, these are, you know,
We don't know.
you have less than 3 months of funding here.
Oh, okay. So is it like a contingency, like we,
Yes, sir.
We're supposed to have 6 months.
In a perfect world, you would have $9 or $10 million
Yeah.
of reserves. You could take an impact, a sudden shock claim. You could actually project claims out for 3.5 years. But you can't do it when 5.2 million and 20 or 30% of it is projected dollars.
Mr. Garza, let me add to that. So what he's trying to communicate is, and we had a conversation about that. To Mr. Suarez's point was that, you know, when we saw these numbers, we said the same thing. I mean, it's in the positive. Why are we considering all these potential changes? But the more we look at it and the more we talk was, yes, our fund balance is in the positive. Yes, it's pretty significant. But in cash, we have $3,329,676 as of June 30th. So to his point is that that's really what we're working with. The rest of these entries that make up this fund balance are projected rebates that we still haven't gotten, but that we expect to get. So we're booking those as of June 30th, but it's not cash in the bank. We can't use it to pay claims. And so if we were to have 1 or 2 or 3 very significant shock claims, now we're potentially cash strapped. And so the line item for general fund transfer, that was a discussion with the business office that said, okay, we're not going to increase our employer contribution as far as our budgeted amount. But we're reserving $1,500,000 that if we get into a situation where we're cash strapped a particular month, we haven't collected premiums, but we have to pay claims, there's enough money in there to pay our claims, and then we collect premiums the next month and things stabilize, and if we have to do that again next month, there's a
kind of like a
reserve
cash
in there
flow?
Exactly, it's cash flow. And so, Ms. Richards is not here to.
Yeah, she's right there. She's nodding her head saying you're right, so.
Okay, good. I'm glad. I was
If you
hoping
go
she
like
was
this,
here
we'll
to-
call you up.
Hoping that she was here to back me up on that, because that was the discussion that, it's not in our fund, but it's reserved to be used for the fund.
So we're familiar with the ultimate fund balance. We have an ultimate fund balance in our general.
Yes.
So you're saying our ultimate fund balance for this should be around $9 to $10 million.
In a perfect world.
We established that it should be at where we are now, and it's a moving target. The 3 months worth of claims, it's just shy of 6 million
Okay, so 6 million's where we should be at.
in cash.
In cash,
In cash, using
In-
Mr.
in
Garza's
hard
strategy.
cash.
and hard cash.
Using Mr. Garza's strategy.
Okay, that makes sense. That makes sense.
If we can move to slide number 9. These are the contributing factors. And we discussed this a few months back. The media is going to contribute to the cost. You're gonna have the constant high cost of specialty drugs. You're gonna have the high cost claimant. Advances in medical technology. Increased utilization because people are now considering healthcare a right, it's no longer a privilege. And then you have the final one. Nobody's looking for treatment, they're looking for a cure. So the cost will continue to escalate. So the numbers you see today are gonna be totally different in 3 years. I wish I could find a solution, but it just doesn't exist. So as we go to slide number 10, these are the strategies. On 2018-19 strategies, we're going to target employee rate adjustments, implement side of care benefit plan changes, implement a closed formulary, drug formulary, and adjust ER copays.
Roger, on the ER copay, there's no doubt that the influx of freestanding ERs that we have in the area contribute. There's a lot of our staff who think that's urgent care, or I shouldn't even say that because urgent care still bills a higher rate, so they think it's a night clinic, and it's very costly to us. So what you're saying with this ER adjustment is copay is that they'll be significantly higher for the urgent cares for the ERs as opposed to a true night clinic.
The strategy here is to encourage people to utilize their doctors as much as possible. We're trying to avoid the individual that gets a sinus headache in the middle of the night and decides he's gonna go to the emergency room to get treatment. And as anybody involved in healthcare will understand, it's a $1,500 ER physician charge, and then we're gonna have a $2,000 ER cost.
Well,
So you look at
but that's what I'm saying though,
$35.
but what are we specifically doing? Are we lowering the copay? In other words, our night clinics, are we considering waiving the copay for night clinics? How many night clinics do we have in network? Hold on, because there's tons of night clinics out there. There's some that are open every day in our network. There's one that's open regardless if it's a holiday. They're open till 11. They're open from Sunday to 3/11. Are we doing anything special with them to promote them to our staff? Yeah, because what you said is we want them to go to a regular doctor, but let's be honest, our teachers don't like to miss during the day. They don't go to the doctor during the day, and then what they do, when they do go, they wait till they're very sick. So I think what we probably, one thing that we can do is really promote these ERs. I know we have PSI, or that they have a night, but there's tons of other ones, and I interact with a lot of them, ask them, and they're willing to work with us, offer discounts. I mean, if you offer a pilot or something, yeah, go ahead. I mean, night clinics.
We're on the same page.
Okay.
We don't want the individual to go from being slightly sick to being a chronically ill individual and going to emergency room. What we don't want them doing is going for routine care in the emergency room.
Right.
So I'm gonna be the first one to tell you, if you're having chest pains in the middle of the night, go to the emergency room.
Right.
If you believe that you're having some type of condition that is life-threatening, go to the emergency room. But if you're having a sinus headache, we'll find a alternative to you, so we can go to see the doctor in the morning or in the afternoon or the following day. Or calling a physician in the middle of the night and asking for some type of treatment. We're just trying to control the cost from all these freestanding ERs that are popping up all over the place.
But what is the actual number are we spending? I mean, y'all have the claim data for that, so can we get that and look to see where we're at, who's our highest offenders in terms of who our staff, not highest offenders, but high utilization that our staff is using on a regular basis? Because, there's some, for example, in Medicaid, you spend $2 million for dental care at the ER. That's obviously inappropriate. So then, if we have the same situation that's, I'm not saying it's happening with ours, but, we have people going to ER that are not using it for the right reasons. We should be able to outreach through our carrier, through the representatives, or through our staff saying, hey, we have a network of night clinics, they're open on this day, and it's gonna be cheaper for you. As you go to the ER, you're spending, $200, $100 copay. If you go to this night clinic, it's gonna cost you $0, $5, something. For me, for most people, they don't understand the difference, but if you talk to them in dollars and say, these are night clinics, they're only $5, I bet that will change behavior. That will make sure that they're using the right one. So I just, I like what you're going with this. I just want to see if we can get a little bit more into detail, because that's something we can control. That is something
Absolutely.
as far as our members.
Absolutely.
So if I may, I can add to some of the things we're doing now, and then we're gonna talk about what's
Okay.
in here. So your first question was about what are we doing to promote them? So, the majority of the last part of the school year is when I was going through all campuses, giving some education on the benefits, self-funding. That was one of the key things we're stressing. We're seeing the data that shows that our ER-related expenses
We're going down.
are going up.
Oh, well, there you
Going
go.
up. And it's because of these freestanding.
Right.
ERs. So we know that's part of the problem. And so we're educating our employees, as you said, that there's a lot of night clinics available. So we're providing lists, we're keeping our own list, we're distributing it to our employees. Right before the summer, we had I don't know what we called it, summer. Yeah, it was a bag full of, it was an MISD branded bag, and inside was a list of night clinics. We had information on the call-in number for our nurse line, so those are all
Good.
tools they can use instead of their first response being to an emergency room. So we're doing that part of the education. Now, something Mr. Garza wasn't going to speak to because it's not here, but I think it's a good segue for on our voluntary insurance products. One of the value-added services, some of you were present, the vendor is offering us telephonic or video, MD Live is what it's called. Basically, it's
Telemedicine.
telemedicine, visiting with the doctor, and it's at no copay to the employee, no
That's
cost
awesome.
to our plan. And so I think that's going to be very, very important, and I think it's going to help.
Can you write a script off that?
You can. Yes,
Awesome.
You can. So I think that's going to be a very great benefit for our employees, and it's coming at no cost to them or to our plan. So we didn't consider that savings, if at all, here. I mean, we don't know how to quantify it anyway, because we don't know how it's going to work. But I expect our employees will use it. And hopefully that maybe steers them away from their first reaction being, well, let me go get up and go to the ER, to the urgent care center. So hopefully that's going to help. Now, in terms of ER copays, and we're going to talk a little more detail when we get to the next document, we had a long discussion about what's a significant ER copay and how much do we want to really set as ER copay. So what we're proposing, and I'll just jump to it now, is to double it. So we'd be looking at $100 and $200 depending on the plan. Now, is that enough of a disincentive for somebody to say, I'm not going at all, and I don't know, but we struggled with that because we don't want to make it to where folks that need to go to the emergency room
Absolutely.
don't go.
Absolutely.
So that was a challenge. So we had to come up with a number that we felt comfortable. I said, okay, it's definitely too low as compared to the industry and what's out there, but how much is too high? So
What would be the copay for a night clinic in
the
comparison?
night clinic as it stands right now, it's a standard copay. We don't have any special arrangements, as you were mentioning.
Right.
Any night clinic. We attempted an RFP for that kind, and I'm not sure if the community out there doesn't understand when we do these RFPs that that's what we're looking for. We had the same two people respond. So one was the PCI clinic and one was a hospital system. Now, we had a couple others that didn't fit into the model that were completely unrelated. So we didn't pursue those. But this was the opportunity for all these folks to say, okay, I want to partner with McAllen ISD, and we want McAllen ISD employees to come here, and this is what we're willing to do for them.
Could we offer, on the flip side then, incentivize from our end, a rewards type of, some companies will, if you utilize the right doctor and it's appropriate, they'll send you a rebate, for lack of a better word. I don't know what the insurance word is. If you use the right the right night clinic, for example, and don't go to ER, they'll, if it's $20 copay, they'll give you back $10 or
I'm
something.
familiar with those models, they're called shared savings.
Shared savings, there you go.
Savings. And I personally have heard firsthand experiences from other employers who have used them successfully.
Mhm.
Here, I think we've talked about it before, that the concept of shared savings didn't pass the review by our legal preliminarily.
Okay.
That shared savings, those are technically taxpayer dollars that need to stay within the fund, and we can't reward employees. Now, we haven't explored it in a while again, but I can tell you preliminarily, that was the response, that it's money that should stay in the fund, you can't give it away.
Right. Well, I would argue you're not giving it away. You're incentivizing, which we're self-funded. If in other words, if someone's going to the ER once or twice, and they're costing us $1,500 per visit, as opposed to go down to a night clinic, for something that's more appropriate, and we give them back instead of $20 copay, right? That's what the copay is.
Yes, it's 20 or 30, depending on the plan.
Right. So, and you only charge them half. I mean, that's incentive. It's a business decision. I don't think I don't think there's anything unethical about that, but that's just my opinion.
I've seen models that will actually pay to fly you and a loved one to like the most
No, I'm not talking that. I'm just
high-quality
talking, yeah.
care
Yeah.
facility, because at the end of the day, that care and that cost is going to be less, and so you're going
Right.
to save, the plan's going to save, the employee's going to save, even with paying those expenses. So
See, even
that's on
the-
the extreme side of the
Right,
cost.
but on shared services too, or these incentive programs, they also work well if for example, for me, I get certain amount of points if I go get a blood test beginning and send it. And for someone my age, 50 years, there's high risk for a lot of things. Maybe I don't go to a doctor on an annual basis, but if you do and you get that blood work, they can catch that diabetes early. They catch that hypertension where it's a lot earlier. So I kind of like those programs because they do work. They do. It's catching them early and helping saving money on the plan. So anyway, I'm just curious to see why we couldn't look at it for us to for a cost savings measure. I'm sorry, kind of.
It's okay, you're doing great. Good points, all good points, and it's a discussion that,
If we can, turn to the strategies pages and turn to page number 5.
You have it in front of you, well,
Yes.
it's kind of loaded, but I can tell you that because of the number of, much of the data that's in there, it's probably better if you look at it on your phone.
That is correct. And you should have a copy of it.
Yes.
On page number 5, you see a completed and ongoing strategies that we've done in the past 2 years. The first one, you'll see we've completed the pass-through pharmacy contract and formulary management. We've also done the out-of-pocket limits on our health plan. We've conducted a claims audit that was concluded on 5/14/18. And we also did the pharmacy chain exclusion on 6/1. The ongoing is the wellness programs, which we have the on-site food clinics. We're conducting employee outreach and education ongoing, it's an ongoing issue. We're doing the direct provider contracting with, so far we have PCI on our system. And we're doing the cash flow analysis, and that's ongoing as well.
Mr. Garza, real quick.
Yes, sir.
What were the findings of the claims audit, which was supposedly completed on May the 14th, 2018?
They were nominal in terms of the claims that they audited. What we did recognize is the fact that the discounts as deep as deep as they allege that they are basically within industry standards and they're not shockingly deep.
One of the concerns that was discussed last year was that the carrier was automatically paying certain amounts. If it didn't meet a threshold, it was just automatic. They weren't reviewing it. Did this audit find any aberrations of that happening and what could have been paid or should have been paid versus what was paid?
They did not. What we found on our own was the fact that is basically they have a standard it's a cookie cutter system. For example, the dietary programs, they didn't have any specific individual requirements. In other systems, they might apply the same way across the board. We'd have to identify them individually.
Well, in that particular, that's one of the cases that was discussed, that there were employees that were saying that they got their dietary issues resolved under the plan, and others that were not getting it resolved under the plan, or for lack of a better word, paying. So did the audit identify those that were paid under the plan and should have been, or not, or those that were not paid but should have been, or not?
So,
I
Mr.
think
Garza,
the audit only identified what was actually incurred and paid and what was actually necessary to be paid.
But did it include the dietary part I'm talking about? Because that was at the center of some of the conversations over a year ago.
Yeah, I think it's a deeper conversation in terms of what we identified, meaning Mr. Silva and myself, was the fact that the carrier had approved certain reimbursements for this dietary program that wasn't necessarily required for certain employees.
Okay, thank you, Mr. Sid.
yes, so unfortunately, I don't have it with me. We can certainly get you a copy of the report. The findings were very minimal in terms of deficiencies, if you will.
Okay.
I do have a summary response from the auditor that kind of walks through what the results were. There was a couple of points where they said that because obviously Blue Cross has an opportunity to respond to the audit, so they go through the sample claims, they evaluate whether they're paid according to the contract, whether they're paid timely, all those contract provisions. And so at the end of the day, there was a small set, and I say small, and I don't have the number with me, but it was very nominal in terms of dollars. And Blue Cross did argue the point with the auditor and saying they disagree. They're going to agree to disagree. And so there was some things that were identified by the auditors said that they felt Blue Cross should have handled differently. Blue Cross felt different to that. But in terms of overall, the term the auditor used with me was, it was a clean audit. You should be comfortable that we did not find anything that should alarm you. Now, I can obviously get you a copy of that report so you can look at it yourself. But that's what made us feel more comfortable that, okay, that part of it is fine. Let's move on to, okay, what other things do we need to target? And so that's what led us down, okay, now we need to look at other things. As far as the administration of the plan, while yes, as Mr. Garza pointed out, we actually stumbled across that situation just from hearing employees talk to us. And so when we inquired, we found some discrepancies on, okay, well, this employee is saying this employee is saying that. Let's look at the claims, and that's when we realized, and they were able to confirm for us, well, yeah, that particular claim ran through the system, and it didn't look for this, so therefore we got paid. But that was addressed separately from the audit.
So it wasn't, from what you're saying in the audit findings, it wasn't a trend and a widespread one. There were aberrations, that there were some because of how it was worded or how they were submitted that got paid, and others that were reviewed or possibly how they were submitted did not. And they found them both to be valid.
I think that's a very safe statement that there wasn't a trend there that suggested claims were not being paid appropriately.
All right, sir.
Yes, sir.
Thank you.
Just
I'm sorry, but conversely, they weren't paying claims that were not covered under the policy, because that was, again, the conversation we had back then, and why the audit was asked, they might have been paying some.
With the exception of those that I mentioned, that there's definitely some where they did feel that.
Right.
It was a sample claim, and they kind of annualized the cost, but even that cost wasn't a whole lot of dollars. Matter of fact, the auditor said, now it's up to you if you want to pursue it, and if you want to engage us to try and pursue these dollars that we feel shouldn't have been paid. But the numbers were minimal.
And by sample claim, who picked the sample?
The auditors did.
Auditor, how many claims were
I
sampled?
believe it was 275.
And out of those 275, how many were of the dietary nature, or were they across the
They
board?
were across the board since it was random, so I think there was some target areas, I can't tell you which ones they were, but there was some target areas based on discussions we had. I said, okay, make sure you look at this, make sure you look at this. But for the most part, they were random based on their algorithms and their formulas and things the auditor had in mind to go into look at.
If you don't mind sharing at the very least the summary and the
Absolutely.
responses, and then if we have a chance to visit at another time, it'd be great. I appreciate it. Thank you.
Just
Thank you,
to,
Mr. President.
I'm sorry, just to follow up real quick on the outgoing employee outreach education. And Mr. Garza mentioned PCI right now. And one of the points that I was bringing up earlier, I just want to make sure I get it in. It's probably under here. Their hours, and again, PCI is a great clinic. They provide good services, so I'm not at all, talking about them as far as them a clinic. But their hours, they're open 8 to 6 during the week, and on weekends they're closed. And the teacher, for example, they're so stubborn. They're sick. They don't want to miss. They want to be there for, and I mean that in a very positive way. I mean that's the reality. They don't want to go, and most of them stay after school late. They don't get home till late. 5:36 is a good day. Is a good day. So I guess that's my point. That I think we need to really, have a tier network for night clinics. Whether it's lower copays, doesn't matter. But I think there has to be a little bit more education out there, like which are the night clinics are under Blue Cross, which ones will take them, and what are the hours. I can rattle off one, like the one I told you that's open every day, even on a Sunday, regardless if it's a holiday. And those are the type of clinics we need to send our patients, our staff to and their dependents. So anyway, I just wanted to kind of emphasize that.
And we are doing a lot of effort to encourage the standalone clinics to work with us. They just don't want to get into a competition with these standalone emergency rooms. So, but we are getting the ones that are looking at staying open till 10 or 12 midnight, which is basically I guess they call it the peak,
Right.
when people start accessing those clinics.
Yep.
Mr. Seaman, I'm sorry. You had mentioned about one of the things we're looking at, no additional cost. Right now, we have the registered nurse or nurse, I gather, but you're looking at this additional one. I can tell you as a retiree, I get that, and they send me an app, the company, to put on my phone, so as I travel or whatever, it gives me access. And then they help me locate if I need, follow-up. But a lot of it we can do face-to-face through symptoms like, and resolve a lot of things. So I'm really, really interested in that, especially if it's no additional cost. Because if that can be provided to our employees, it may
Absolutely.
prevent some of these concerns and these issues.
When you have a child that's sick, to your point,
Yes.
has a little bit of fever, low grade, a little bit of symptoms, you just want to be able to talk to someone as a parent, as a mom, as a
Exactly.
dad. So if you're able to FaceTime through the telemedicine, and even get a script where they can call it in, and a lot of these pharmacies deliver, there could be something at your door potentially within the next hour or two without having to leave your home. And they're going to the appropriate level of care, not the freestanding or even urgent care. Urgent care bills us at a higher rate than the night clinics, right? I mean, that's true across the board.
On your
That's
screen,
correct.
I took the opportunity to ask Mr. Miller to load something. This is a sample of what we provide our employees, and it's loaded to our website.
Right.
So we created the.
Oh, this
you know,
is good.
And so it's the list of ones we came up with. We asked for some feedback. We looked through ones we knew about.
That's awesome.
And we're encouraging our employees to let us know if you know of one. let
We'll
us
add it
know.
to the list.
We'll add it to the list, and we distribute it again. So we've already done that on at least 2 occasions where it grew. So we posted it, we announced it, and then this was the list we also sent out toward the end of the summer, so that they had, and some of the feedback was really good. They said they posted it on their refrigerator, and now they know that they can go and look at that real quickly. So
Do we have it on our website, Mr. Silva?
that's on our website. That's where
Awesome.
we're loading it right now.
Awesome. Where's it under?
on our McAllen ISD employee benefit site.
Awesome.
Thank you, very good.
And we're still
If we
trending up?
can, turn it,
Well, this is one of the reasons we did this, to hopefully trend down. I can't say that, I'd like to take credit that all that education helped. As Mr. Garza mentioned, that we're projecting our claims to go up and up and up. They didn't go as high as we were projecting
Awesome.
it, but we definitely had a very targeted campaign to educate our employees. We're self-funded, what it means, what could happen if we don't start taking a more consumer-friendly approach,
Yeah.
more informed consumer. So hopefully that
That's
has
good.
helped,
Yeah.
that they
That's good.
understand
Yeah.
and it more and are using the benefits wisely. We shared with them all the tools we have available to comparison shop their benefits in terms of the providers. So hopefully all that's working.
Good work.
Well, if I may, I appreciate the education of our members as to their benefits, but are we talking to those providers out there and saying, this is an opportunity for you to step up and shine? Is it, because I know that you mentioned you put out an RFP and two people replied, and one was our usual PCI and one was the hospital system. Are we knocking on these other doors and saying, this is an opportunity for you if you want to do business with McAllen ISD? I mean, I understand your role in growing the membership from within, but are we talking to the providers and saying, you know, we have this membership numbers, we can potentially include you on this list, but we're looking for your cooperation as well?
Well, to answer your question, we've not done a lot of that, other than, folks come and see us and talk to us about, here's our clinic. We take that opportunity to talk to them about these opportunities. We've not done a wide mass type opportunity to bring them in. We've talked about maybe doing I think they call it a request for interest through our purchasing department, where we target medical clinics, maybe all night clinics, and bring them all into the room and talk to them about who we are and what self-funded, the important, because most of them don't even realize that.
Right.
They think Blue Cross is our insurance provider. So when they hear, what do you mean self-funded? What does that mean? So they don't even realize that it's the district paying for those claims. So I agree with you that we need to do a better job of that, and we started the conversation, we just need to follow through.
And as much as I appreciate following the RFP and the RFI, it may just take a phone call from somebody in your department or from yourself saying, we have this event on Thursday, it's an opportunity for you to come in and grow what you're doing with McAllen ISD. If you're even working with us, we'd like to have you come in and go that route, because, when we publish an RFI or an RFP, there's a lot of people that just don't comprehend the jargon. And they, for that reason, they'll just, walk away from it. So I think that's an opportunity that we're missing out on in getting some of these night clinics to come in and say, I can do these services and here's what we can do.
So we'll definitely look to do a better job of that.
Thank you, sir.
Just my last question. I got this on the Med Live. Awesome. It's by Colonial Life. What's the utilization of this? Has it increased?
It's brand new. That's what
Oh.
I'm saying. It wasn't even going to be
That's
your
awesome.
material.
Yeah.
Because it's brand new. It was all part of a separate process where the vendor offered this as a value-added service unrelated to our medical plan.
Right.
And so, but it's directly related. So it's going to be part of our promotion as we open our enrollment, that this is now going to be available.
Awesome. This is good. Thank you for doing all this, Andy. Roger.
And
Sure.
I don't mean to keep you from asking questions, but the meat of it, the strategic plan, we still haven't even.
We haven't started yet.
Yeah, so,
yeah, that's the fun part.
yeah, that's where he gets into the details that we need to get to about what these strategies really are. So if it's okay, we can jump into that. I'll let Mr. Garza open it up. And again, it's probably
Yes,
not.
that'll be on
up
page
there.
number 6. On 18-19 school year, these are the proposed implementation strategies. If you look on the left-hand side, it'll give you the number and the priority and the target areas. As you can see, our strategy is the premium adjustments. But please, look at the bottom where it says we're excluding employee only. We're not going to target the employee only. We're looking at increasing the funding, The estimated savings is approximately 770,000. The timeline is January 1 of 2019. And it's going to align the premiums to the market levels. On number 2, the implementation of the side of care. It's a benefit plan, a change. It's already in the works. It's going to save approximately $700,000 a year for the next 5 years. The target date is 10/1 of 2018.
Roger, I have a question for you.
Yes, sir.
When you're saying it's gonna save us $700,000 a year for 5 years, are you also assuming that in the next 4 years, the rise of medical bills are gonna rise and that those numbers have been plugged in as well? Or is that
So what
assuming that the
we're-
rates
so
stay
we're
the same?
anticipating there's certain injectables that can be administered at a doctor's office or other clinics that will save the district considerable amount of monies. And in just one that's been identified, it's almost 700,000.
So what this is something we've talked about before that we've seen, just like we've seen trends in our plan. We saw one particular one related to injectables. And so this particular benefit plan change, Blue Cross is already prepared to administer that we'll see an immediate savings in our claims because our plan is now going to apply that benefit differently. And so what that reflects is that we know with certainty that claim cost is going to be reduced.
And I don't know if retroactive is the
There's
word.
no changes in the administration, meaning they'll still get the same drug, but the side of care will change.
There's no issue with like being retroactive, hey, we were going here before, that's gonna change, right? Are they
Yes,
gonna have
yes,
to-
sir. It's just like any other plan design change that we might consider. Effective on this day moving forward, here is the plan and the plan benefit, and here's how it's administered. So in this particular situation, you probably should be aware that since it is a very specific type of situation in drug and facilities, anybody who might be already receiving treatment, they're going to get notified and say, our plan is changing on this date, and here's what you can expect, and allow them an opportunity to talk to Blue Cross. The Blue Cross is prepared, obviously, to make sure that they get the care, continue to get the care.
Mr. Silva,
Yes, sir.
they'll also be informed that if it's incurred medical, how much time do they have in order to make a claim under the old plan? In other words, it's incurred prior to the changeover, but shouldn't they have or wouldn't they have a time frame to submit?
Well, it's actually, the cutoff would be when it becomes effective. So right now, we're proposing 10/1. So if a claim was incurred prior to 10/1, it gets processed under the old
Old plan.
benefit plan. But any claim with date of service after 10/1 would be
Obviously.
on the new benefit plan.
So even if they waited 9 months to submit their claim for, under the old plan, they could still get reimbursed based on the old
It would still be
plan?
under the, yes, sir.
Okay.
That would be how, and I don't know, Mr. Gossett can chime in if he feels differently, but that's how typically they'd be handled.
Now, are we looking at doing, I'm sorry,
It will, but
go ahead.
they won't incur that charge unless it's approved by Blue Cross. So after 10/1, if the individual attempts to access that injectable,
Mhm.
they would have to have pre-certification, so they'll tell them where to go get it.
Okay. Yeah, because that can happen at times, especially when they're planning their surgeries and things of that nature. Now, the other question I had regarding that, are we looking at, right now we have 2 plans, the basic plan and the high plan. As we go forward, are we looking at 1 plan or still 2 plans?
That potentially, and I'll let Mr. Garza discuss that would potentially maybe year two.
Okay.
And if not one plan, it'd be two plans, but one in the reference-based pricing model, which is what we're gonna talk about, which it would be similar to what we have, and that's the part that we need to iron out. What does it look like? How is it gonna work? But it's completely different approach to our PPO type plans now, so
Okay.
that's something that we're looking for year two.
Now I'm with you, so as I go through this, or you go through it, I understand where you're coming from. Thank you.
Go ahead, Roger.
Thank you. And then we have, number 3, which is we're gonna implement a closed formulary, drug plan. What it's going to do is reduce the number of types of medications that will be available where employees can access these. So we'll condense the list to the lower costing drugs. And we anticipate we're going to be able to save approximately about between $400,000 and $500,000 a year. And we're hoping to implement that on January 1. So we'll have a grace period where employees will be able to transfer. They'll be notified by the PBM. So we'll have some time spent there, so they'll have time spent as well.
And so let me add here that I want to make sure to point out here that this is definitely a more aggressive approach to date on our pharmacy plan. And so it's something that definitely our employees need to be aware of if approved, if that's where we go. But it's definitely something we're bringing forward as a recommendation. The potential reduction in claims costs to the plan are significant, but the potential disruption to some employees could be significant. Why? Because they may not have access to the same drug after this gets implemented. In some cases, it may move from a lower cost tier to a higher cost tier, so it'll continue being available, but their copay goes up. In some cases, a drug will not be available to them at all, they're going to have to switch to an alternative drug. Now, something that is already discussed is that there are alternatives, and it's not going to be a situation where there's no options. There's definitely some options, but those options might not be the one that the physician primarily prescribes. It might not be the same one that they're currently taking. So it is definitely 2 or 3 steps above what we're doing now, which is prior authorizations, which is just verifying that the drug is clinically appropriate and safe and is the most cost effective for the member. That's what we're doing now. This takes it up several notches. So I just want to make sure you're aware of that and we have an opportunity to discuss that if you have any questions about that.
No, I think it's great. And I think we have to emphasize that no one is getting any less health care by implementing these changes. The adequacy, the quality of health care is going to be the same, even with these changes.
I do have a question in that regards. There may be some individuals currently with us, and you probably already answered it, and if it is, just say it still would apply, that are on maintenance drugs. In other words, they get their 90-day supply, and it's been that way for a period of time. They're going to have to now go back to the physician, look for an alternative, go through the healthcare provider as to what will be allowed now under the plan, and then reestablish their plan, their maintenance drug on a 90-day plan if that was available.
Potentially, I can't tell you with certainty that there's a significant number of maintenance drugs that would fall under this closed formulary. But if they do, then the answer is yes, because that prescription is no longer going to be available to that employee. So they have to switch, and now that they switch, they're going to have to get another prescription from their physician, and that prescription would have to be the 30, 60, or 30 or 90 days, whatever that is. So potentially, yes, that's another one of the potential disruptors.
But the key to say, going forward, as Trustee or President Vela stated, is that it may not change at all for you as you go through this process, depending on where you are in the current treatment and the current care you're getting. So it should not automatically be assumed that, because you mentioned earlier that in some cases they can go to a higher tier and get a different drug at a higher tier because it is allowed under the closed formulary.
In some cases, I should also point out, it's the minority. They could be going to a lower tier, and they could be saving money. So that needs to be said too. Now, in terms of how many folks would be impacted, this is already, obviously, it changes. So we have prescribers, different prescriptions coming in every month, every day. But when they did the analysis for us, at that point in time, there was 290 folks, 90 instances that could potentially be impacted of 49 different drugs. So that's the kind of disruption that would happen almost immediately, that those individuals filling those drugs will now have something else happening. In some cases, lower cost, in some cases, higher cost, in some cases, moving to a different drug.
How many, what was that number again?
So 290
Out of 3,300 that
out
are
of
currently?
3,300,
Wow.
and 49 drugs.
Okay.
But again, that's current utilization. Now, every new prescription moving forward would fall under this new criteria, and potentially that situation happens, moving forward to somebody who might get a prescription, they try and fill it. This then it gets administered and say, hey, wait a minute, McAllen ISD plan says you can't have that one. It's only these over here. So that would be what the experience might be for our employees.
And again, it's between them and their physician in conversations and also with the carrier. It won't necessarily be with the pharmacist at that point, because by that time they will know when they go to the pharmacist what's been allowed.
The pharmacies definitely have a lot to do in that, because they can, and I think they have access to, well, your plan doesn't allow this, but it does allow this. And so they can help educate. I'm not sure if they can actually change the prescription under those circumstances, but they definitely will have access to what our plan is saying is eligible, and I'll be able to tell them, I'm sorry, this one's not covered, this one is.
And that's what I'm trying to get at. And if it does happen that way, I would gather that the pharmacist would be getting back with the physician, so there'd be clarity there.
I think that's
And how
as
it's
well.
completed and filled, right?
Yes, right. And the other thing I can say is that also, we're gonna have an outreach, our pharmacy benefit group, to make sure pharmacies and doctors are aware that this is the approved formulary list. So hopefully that they'll start using it, and we won't get in situations where they try and fill a prescription that's not even covered.
All right, thank you.
So
the
the doctor will know what medicines are approved?
We're
You'll pass
hoping
up-
to educate them, yes, sir. Now, again, I don't know that they'll automatically use it and say, okay, this is a McAllen ISD employee, let me look at this list. Sir, I don't have any kind of feel for how that works, but there'll definitely be outreach to the clinics, to the doctors, that for McAllen, this is changing.
There are some physician offices that load the formularies into the plan,
Yeah.
so they can have a drop down of what's available for them. As far as the pharmacies, this isn't something new, and this happens with every single plan, every single employer, every year, every day, something changes on somebody's plan. And, because every day we get, well, it was covered last month. Well, we changed months. So what you got last month is not available this month, but this particular one is. And as far as most of the time, we call right then and there to get it switched, if it's one of those that you can do.
I think in the frame that we're dealing with today, is that all physicians are required to go to a database system. They had to go to electronic, and they all had to set all that up. And that's what makes it possible, because that's how they're able to get the updates, either automatically or enter the information, so that you, as a patient, they're gonna be able to see. They even
Yeah.
tell me at times, oh, your pharmacy is such and
Right.
such, so, yeah.
So yeah, and when there's a rejection, because it's no longer on the formulary, the doctor's office gets notified electronically almost at the same time.
Exactly.
But then what you're gonna do is you're going to start educating them now, and you know who's on which drugs will be excluded, so you can go target that person individually
There's
and
going to be
strategically.
targeted letters also to the
Yeah.
members that are currently on a drug where they're potentially be impacted, yes, sir.
Yeah. You're trying to
With the-
minimize
With
the,
the alternatives, so that they can have an opportunity in advance to go see their physician and change it.
right. You're trying to minimize surprises, and I think the way you've got it covered, there will be no surprises.
You're talking about January 1, right?
Yes, sir.
So does that letter come from McAllen ISD? Does it come from our pharmacy benefits manager? Who does it?
Typically, it comes from our pharmacy benefit manager. We've talked about maybe co-branding so that they understand it's coming from McAllen. But typically, it's on the letterhead of the pharmacy benefit manager. We'll always send something through our whether email or some kind of notice to campuses and departments to say, expect this, and it looks like this, and this is what it's gonna be about. So hopefully they'll know that once they get that letter that has that, you know, who are these groups? Because that's the other struggle.
Right.
Who is American Healthcare? I don't recognize them.
Right.
So we try and close that loop, so when they see it, they don't just throw it away. They know it's something important, it's benefit related. So we try and work from both sides.
Well, I think, you know, much like we did at open house yesterday, the remind and sign up for this and make sure you get, you know, involved in this. I think we need to hit everybody with the registered letter, the email, the text message, you know, even at times if we've got to go and say, listen, Mr. So-and-so, I know that you're on this medication. Well, starting January 1, that medication is going to have to be switched from this. You can get it, you can keep that medicine at a higher cost. That medicine may drop in price to you, or it may be done away with entirely, and you have to look at one of these options. We need you to consult your physician. Thank you.
Amy, on that, I know we're gonna give them a grace period of 3 months. Are they gonna get the letter right now, and that grace period, so it ends January 1st, or January 1st, or are they gonna be told and then they get a grace period after January 1st?
It's at our discretion. The timing is at our discretion. We can implement it January 1st, and if there's plenty of time to do it from now to January 1st, we'll do that. If that window closes, we have discretion to say, well, the letter goes out, and you have up to 30 days, up to 60 days to do it. And we have the discretion to even grandfather if we feel that this is gonna be a significant disruption going in. Okay, let's grandfather them for 30, 60, 90, whatever we feel. That way it allows them plenty of time to understand it and to make plans. Now, for new prescriptions, it's effective right off the bat. But so as to reduce the disruption of the current utilizers, there's a lot of different strategies we can implement. So a lot of flexibility.
When you have a final recommendation on which to apply?
The recommendation as it stands right now is that we'll present these to you at the next board meeting, and if we can get it approved then, immediately we can start sending out notices, and that gives us plenty of time so that we're at January 1. And
So
then-
at our next board meeting, you'll have a recommendation on how to, whether it's to grandfather, 60, 90, January 1, all that, okay, thank you.
You mentioned something about those grandfathers. I know there are very isolated instances where we have one drug, one patient, which ones I'm talking about.
Yeah.
We've accounted for those as well, right?
Yes, sir. Those are unique situations that we
Right.
can handle the same way as we have in the past.
Okay.
Yes, sir. We just need to make sure that our PBM's aware of it in advance so that they don't accidentally toggle a flag and there'll be a disruption right away. So, yes.
Okay.
That's fair.
So
Is that it?
if I may, I'm gonna jump in for Roger here. He can jump in too, but I want to touch base on a couple of things real quickly. On the second page, you have number 5 through number 10. A lot of these are education related, outreach related, things we're currently doing, we'll do. I want to talk a little bit briefly on number 8, dependent audit. So that's something we've talked about before. We've talked about how we're going to do that. Could we budget for it? Do we do it administratively? Well, this is another program where we can now announce to you that we're going to be able to do it at no cost to the district. So through that process of the voluntary insurance product, just like the MD Live, this vendor says their system is not only set up, their enrollers are able and will do this dependent audit for us. So this is going to happen also. The plan is to do it in an open enrollment period. So every employee will have contact with an enroller, and if you have a dependent child or a spouse on our plan, the expectation is they'll provide proof that they're eligible. And so we talked about that before briefly, that if they're eligible, everything's fine. If they're not eligible, then we're going to have to transition them out of the plan because they should not be on our plan. So that's going to happen, and it's at no cost to us. Yes, sir.
That's great, thank you. I'm glad to see we're doing that, because that was one of the questions I couldn't understand. If you were enrolling, you know, and you have an underwriter reviewing it, why that wasn't happening. So that's going to happen. Now, sometimes things change. Time passes, and now the individual either left or whatever the case may be. Is there going to be a follow-up audit on a regular basis? Like I have to do it every 2 years, where they ask for, you know, additional proof, because I have a 34-year-old, and they kind of wonder why is the 34-year-old still there, you know what I'm saying? So is there going to be that, and
Well,
no charge?
Yes, the answer is yes. Now, the ongoing part of it, and again, I've not seen the system, how it works, but the presentation was that it's set up where qualifying events, new employees, they can't continue until they provide proof. So we're able to do that ongoing. So no more opportunity for somebody to enroll and for us to miss it, to not catch it, to review it. It'll actually stop the system and say, hey, this is what needs to happen. Until you do this, you're not going to be enrolled. So moving forward, it's going to be ongoing.
Fair.
So yes, then we'll have to look at annually or every 2 years to kind of make sure that nothing has fallen through the cracks.
And it'll screen every employee or just the ones that are signing up for those additional benefits?
The ones that are, well, every employee says we're doing it for the first time. Yeah, we're doing it for the first time. Every employee has to have contact with an enroller, and if you have a dependent child or a spouse, then you have to provide the proof. Now, obviously, if you're an employee-only plan member, there's nothing to provide, but you still have to meet with the enroller and go through the process and do an acknowledgement type process.
The key is for dependents, what you're talking about here is the dependent audit will be automatically at the beginning, and then subsequent,
Yes.
whether it's a year or two,
Yes,
for dependents.
yes.
Gotcha.
When we do the audit, can we see if their children go to MISD?
I'm not sure. I guess depending on what the level of information we're requesting, maybe we could.
It can be interesting information.
And another advantage, if I may add, is for everybody seeing an enroller is to update your beneficiaries, because people get divorced, things like that, so. Which is advantageous, plus people say, I don't know what my benefits are, well, you have no excuse if you sit down with an enroller, even if it's just for a few minutes.
You know, you bring up an interesting point, just for edification real quick, you don't have to answer it now, later. If they are divorced, sometimes the children are with one spouse and not the other, but the other spouse is required to pay. That's gonna have to be worked out as
Yes,
well,
sir.
right?
And there might be some challenges there. Mr. Garza pointed out some examples that I hadn't really thought through where there might be some arrangements that
Mhm.
we're not privy to, where the order may be that needs to be covered under somebody else.
Mhm.
But if we don't have access to that order, then we don't know.
Right.
So I'm not sure how we'll work that out, but that's potentially some of the situations happening here.
That could be part of the dependent audit documentation that's required. Fair enough.
So the other thing I want to highlight here, we started talking about it, number 10. So ER copay adjustments, and I focus on the last column because I see you have a typo in column 4. So ER copay adjustments, the proposal that we'll bring to you is to go from 75 to 150 and 100 to 200. So they're doubling.
Oh, so that's 75.
It's on page 7, it's number 10.
So the high plan should actually say 75 to 100, right? That's the typo?
The typo is actually, it should say, from the basic plan, it's going from 100 to 200.
Mhm.
From the high plan, it goes from 75 to 150. So
150,
it's doubling.
gotcha. Thank you.
And so the other one that I think we need to spend the most time on that Mr. Garza can speak to, it's really number 1, the premium adjustments. He alluded to employee only are the only targeted increases, but you still haven't seen what those are, so I want to direct your attention to page number 8. So page number 8 tells you what currently the rates are and what the proposed rates are in terms of percentages and dollars. And then we can talk about impacts on the following page, which shows you, what the impact is in terms of number of employees. So Mr. Garza, if you want to walk them through this one?
Sure. Again, we have the employee only at the current 18-19 proposed rate adjustment. We are actually only making an adjustment on the tier. We're actually creating an employee plus children tier, a maximum of 3 children. That's going to affect approximately 70 employees. And we're going to give them a decrease on cost. And this is under the basic plan. Currently, the employee who has more than 2 children would be paying the family rate. So we think that this is a great incentive for employees that are single and have more than 2 children or 3, it gives them a premium, relief. Under the high plan, we're also doing the same thing, but it's only gonna affect 27 employees. And again, they're going to have a new tier at $460. And they are going to have a relief, a premium relief.
Mr. Garza, excuse me, real
Now,
quick.
if we go back to the basic plan,
Roger, question here.
we are, yes, sir.
Yeah, we have a question. Yes, sir.
Thank you for that information, but how many employees do we have currently that are over the number of children, over the 3 max, if any?
Those are the numbers reflected there. So based on the current census, we're able to identify how many. So it's the 70 plus the 27. And again, the census, when we did the census, this is the count. It may have changed since, but it's 97 that we found that are in a family plan, and they're only 1 adult with 3 children. So potentially, they could now move into this plan, and instead of paying the family rate of the 430 or 572 currently, they'd be paying this new employee and children rate.
I understand. So they're actually, by creating the new tier, they're in a better position, because before, anybody who has more than 3 children is in the family plan, and that's already taken care of.
Regardless if you have a spouse.
Gotcha.
So it's, in this case, it allows for the, as Mr. Garza pointed out, single parent households that have children to be in something other than a family plan.
Got it. Se me prendió el foco, it took me a minute.
It's just maximum of 3 children.
Maximum of 3. If you go into the 4th child, now it's a family plan, traditional family plan.
Which is the last one, employee plus family.
Yes.
That saves those families with, I'm sorry, employees with 3 children about $1,900.
Thank you.
So what we did, we started identifying the tiers that were causing or were not being funded correctly. And we found that we needed to do some contribution adjustments to 3 of the tiers that you have under the basic plan. The first one would be the 2 employees in the family. We're asking for a 22.17% rate adjustment. It's going to affect approximately 22 employees. We again looked at the employee and spouse, and we're asking for a 21.21% rate adjustment. It's going to affect approximately 80 employees. And last, it's the employee and family. We're asking for a 27.6% rate adjustment that's going to affect approximately 329 employees.
329?
329, yes, sir.
Thank you.
We believe that these rates will, for the first year, will make the correct adjustment for the cost of what it's costing the plan. When we move over to the high plan, we're asking for an adjustment to the 2 employees or family of 9.0%, which is going to affect 27 employees. The employee and spouse, which is going to affect 36 employees, approximately 27.2%. An employee and family of 22.3%. It's going to affect approximately 183 employees.
For the 2 employees and
This
family,
will better align your contributions to the costs that you're incurring.
could you clarify, Mr. Silva, he may not have heard me, on the 2 employees and family, it's a 9.07, how many employees is that gonna affect?
27.
27?
27. It's listed there on, there's 2 columns for census, current and proposed.
Oh, okay,
So those are the actual counts.
got you. I didn't see
Why
that.
does the employee family on the high plan go from 183 to 156? Why does it drop down? The same thing on the basic plan, it drops down from 329 to 259 employees.
Because you took them out
Oh.
of the family plan?
Yes, yes,
And then
because there was
put
an
it in
adjustment for those
one
that
kid,
were,
3 kids.
Yeah.
Oh, okay,
Look at the
the
new
27 and the,
yeah,
okay,
so there,
I
it
see.
was accounted for that there would be a shift potentially
okay,
of those folks that can be in that different tier.
I see.
A couple
Sure.
of things that I wanted to point out here. On page 7 of the original slides, just to give you some idea of how we compare with both current and proposed. Mr. Garza went over the different sample school districts that we had, so you can have some idea of it compared. And then, the other point was that, I think he kind of alluded to it. You see on the basic plan, there's 2 tiers that aren't being proposed for adjustment, employee only, as you mentioned, employee and 1 child. So you might ask yourself, well, why not employee and 1 child if we said that we're targeting those that have dependents? With the employee and 1 child, based on the analysis of loss ratios, that one was funded appropriately. So there was no reason to make an adjustment. It was only those tiers that had the most significant loss ratios that are being proposed for adjustments.
Andy, I have a question for you.
Yes, sir.
I'm looking at, I'm back on page 8 and looking at these increases. And obviously, increasing the amount that an employee has to pay is never something that's very favorable. But let's talk about a hypothetical. If I'm employed by the district and I'm on the family plan and I'm looking at a $128 increase, let's just say I'm on the high plan. If I were to get on the internet and try to find an insurance for me and my family, your guess, and I know what my guess is, but would my rates be much higher than what I'm paying with the school district?
I'll comment, and then I'll let Mr. Gaza comment from his experience. I would still say pretty comfortably that this would still be a better value than what you can find through the marketplace.
Definitely COPA.
We're not finding that marketplace rates are better than what you can get. In general, school districts, public systems, they're by far more competitive. I do have some data. This is already a year old, and it has to be because the new survey doesn't come out. Just to give you some idea, the Kaiser Family Foundation, I don't know if you're familiar with that, they do an annual, very broad survey, and we participate every year, so they definitely take into account school districts. While this number is not all school districts, it's across all, just to give you some idea of their 2017 data. This is, in 2017, the average annual premiums for employee-sponsored health plan, health insurance are $6,690 for single coverage and $8,764 for family coverage. So that's annual. So you divide that by 12 for an employee-only plan, $557.50. For a family plan, $1,564. Now that's the total cost of the plan. So here at McAllen ISD, like all the public school systems, there's an employer contribution. So I mean, we can back out the employer contribution from this and kind of gauge where we are. Still, we're very competitive.
In terms of other districts, we're still competitive as looking at what they have, but in addition to that, our plans offer more than neighboring school districts, am I correct?
That's one thing that I can't say with 100% certainty that our plans are richer. I can tell you they're very competitive, and that's one of the dilemmas is that it's very hard to compare apples to apples when it comes to benefits. You have different deductibles, you have different co-insurance percentages, you have different co-pays, you have different ER co-pays. But our plan design is definitely very competitive, and I'll let Mr. Gasa.
And just to set the record straight, the individual employee, their rates are not going up.
Based on our recommendation as stands right now.
That's correct.
Employee-only tiers will not be adjusted.
Okay. And in addition to that, employees who have 1 child, their rates, based on your recommendation on the basic plan, will not go up.
Correct.
Okay, thank you.
Now, and again, I interrupted Mr. Garza, but let me direct you to the next page, page 9. Because there you have a graphic illustration of the impact. So using the census numbers that we have there, the number of impacted employees would be about 795. Those are the tiers we're talking about. Now, within that tier, we have those few that potentially are going to have a reduction in premium, but it is a small percent. But by far, the majority of our employees will see no impact, based on how we're presenting.
Well, in the basic plan, you're talking 431 are impacted, right? 2280 and 259?
Yes, sir, and the 22.
And then when you look at the high plan, it's 386, isn't it? 20, how much is it? 27, 37, 37? Okay.
If our math is correct, the total of all those should be 795.
795, all
Yes,
right.
sir.
Thank you. Out of 3,102, more or less.
Yes, sir.
And in some in a positive way, right?
A small, small number.
97 of them.
Yes. Roger, anything you want to add here?
Well, in terms of the adding an employee with 3 dependents is very aggressive, but it's very generous. And I applaud you for that, because there's employees that are paying the family rate, and you have 3 dependents and 1 adult dependent. It certainly can get very expensive, but I would attribute that to be almost a raise, if you will.
Mr. Sealer,
If we want to proceed to page number 10, unless you have any other questions.
Yes, we have a question, Roger. Yes, sir.
just real quick, maybe you're going to cover in a little bit, if you are, just how much of the fund balance would this change, just the actions that we're talking about? You're going to cover it.
Next, yes, sir. It's
Thank
actually on the next page,
Thank you.
page 10, yes.
Yeah.
Go ahead, Roger.
If we're on page number 10, you look at the 18-19 school year projected cost of the contributions. Assuming no rate changes or changes to our strategies, if we make no employee contribution increases, all things just remaining the same, you'll have a 2018 projected cost of a contribution of $206,143. As you recall from my previous discussion, we're basically breaking even, and that's not, in terms of actuary, that's not good. In the 18-19 school year with rate changes, you'll see a projected potential savings from the strategic changes of $700,000. We will have a cost of a contribution of approximately $1,276,591. Now, keep in mind that just because our cost has stabilized doesn't mean that the trend is decreasing. The trend will always increase.
So to answer your question, sir, if we look at the bottom part of that page, 18-19 school year, that includes the additional proposed increases to those tiers. That's going to raise $770,000 approximately. The general fund transfer that I mentioned earlier, the same assumptions on rebates. We did account for the benefit plan change here because we feel pretty strongly that that's going to be an immediate savings. So it would be a 1.6 additional to the fund balance for a total of $6,697,002, assuming it plays out the way it's here. So that's where we would be at the end of next fiscal year.
Thank you.
Actual dollars.
Fund balance dollars,
Fund
not
balance.
cash dollars.
Okay.
Correct, correct. It's the same.
That's right, that's right. That's right. But where we want to be in terms of fund balance.
It puts us much closer, yes.
Yeah.
Yes.
Now, we can turn to page number 11. We can see our 19-20 school year proposed implemented strategies. Again, we have the proposed increased funding on priority number 1 of $770,448. And again, it aligns our premiums to our loss ratios and to our market values. But that would occur on January 1 of 2020. The second item would be implement a reference-based pricing module to the district. The item number 3, we would change our dental plan from a self-funded to a fully funded program. We would save approximately $260,000. Number 4, we would do more direct provider contracting and expand our outreach to a lot of the medical clinics. And item number 5, we would continue to do our employee education. If we turn to page number 12, we'll see the 2019-20 projected cost of contribution estimates. On our final 19-20 fiscal year, projected cost of a contribution be approximately $746,319. And this would be the elimination of the $18 employer contribution for dental. It'll be reduced into 2 separate plans. And it would remove approximately $1 million worth of funding to the medical plan, or I'm sorry, expenses to the medical plan. If we turn to page number 13, it'll tell us, it shows us the affected population is going to affect approximately 531 employees, which is 60% of your population. 100 of the 531 will receive the premium decreases.
Any questions on these? There's a couple of points I'd like to make, but then obviously I'm open to questions. The reference-based pricing model, we've talked about it. We feel it's a good option for us, but we also feel that it's better to roll it in a very strategic way. It's another one of those that it would be completely new to us. It's more aggressive, and it's something that while we talked about implementing it year 1, because of all the other proposed changes we're bringing, the closed formulary, other considerations like it would involve a second administrator. We obviously need to have an actual plan that we can roll out and where people know what it is and how it works. We're putting it on year 2. That gives us plenty of time to develop it, to educate, to do all of those things necessary to make sure our employees even understand what this is about. Because this potentially would save the employee money, but there's a huge, huge risk that they could be balance billed significantly, because on a reference-based pricing model, we no longer have the guarantees that they won't get balance billed. The hospitals will not necessarily accept what we pay them. They have the right to balance bill. So we wanted to make sure we would have that not only well thought out, but definitely disseminated so that here's the process if this happens, this is what you need to do, here are the steps you need to take. Because if they don't, potentially, we're going to have a huge bill to deal with, and then obviously we're going to have some very unhappy employees. They may have been happy that on the front end their premium is very, very low. On the back end, when they get a huge hospital bill, not so happy. So we definitely want to make sure we do this very methodically. So that's why we initially had it on year one, but we're recommending it year two. Now, the other thing I want to say about 1920, these strategies here are not coming forward to you for approval. This is just so you'll know this is what we're planning to do. There's plenty of time to develop these and ultimately bring these back to you much later. But we did want you to know these are the things that we're looking over a 2-year time span. And so we wanted to be very upfront about that, you know, it can't be a fix all in 1 year. It has to be a lot of different strategies. And in this case, it's over a 2-year period. Now, Mr. Garza mentioned the self-funding versus fully funded demo. Again, that'll be very different for us. Potentially there's some cost savings, but then now we have to educate our employees that here's what the plans are, now it's a fully funded plan, and here's what the cost is. And so now that's out of our control. The premiums will be out of our control, it will be based on our underwriting, and here's what the benefits are. So another education component. So the other things here, obviously.
And how does our dental plan work right now?
We're self-funded just like on medical, so
Oh, really?
we have a benefit plan design. Our premiums are built into everything we're talking about here, and Blue Cross administers it for us. So our employees go to a dentist, it pays based on our plan pays the dentist for those services. And of course, if you're an employee-only plan, you're paying nothing. It's entirely 100% employer funded. If you're in a family plan, there's a cost share.
Mr. Silva, if I may,
Yes, go ahead.
the dental plan has never been adjudicated correctly in terms of how you underwrite the cost. So the district has been funding the majority of the cost. So if you look at your claims that you incur on an annual basis, approximately about $1 million, and you collect approximately $900,000 worth of contributions or premiums. If you were an insurance carrier, an insurance carrier would put a 20 or 30% adjustable rate in there, or a buffer, if you will. So you're underfunding it. And this way, we take that liability off our books and we put it back on the carrier's books.
Mr. Silva, did you all explore the possibility, because you see the numbers of how many folks are in the high plan, how many are in the basic? It's just going to one plan. I'm not buying or selling here, was that discussed and what that might do or not do?
We did talk about that at one point. I will share with you that in a very short period of time, this whole strategic plan had a lot of moving parts, because at one point, when we started these conversations, really the solution that we had was, this plan is underfunded, we need to bring in more funding, and that's the fix. So one of the suggestions at that point was, well, here's the plan, here's what the race needs to be, and let's move on with that. But as we started having more of these discussions, we kind of moved away from that and said, okay, we can continue where we are now with these plans, and there's some other things we can do. So that's a long answer to, we looked at it, but we didn't bring that forward to you.
Gotcha. It didn't rise to the level that
Right.
you felt that was a viable solution.
And one of the reasons we did look at it, because we saw an adjacent school district do that. But my understanding, and Mr. Gaza can speak to that, it was basically the kind of approaches that we can't afford this, and this, here's what we can afford, and that's it. We're not gonna give our employees any options. And so maybe that's where we would have been several months ago, but things did change a little bit that gave us a little more flexibility. But that's definitely something we did consider.
Fair enough. Fair enough. Thank you. You answered.
Hey, Mr. Sandoval, just to add to that, the district is not on the plan is not on a life support. It's maintaining itself at the trend. We just have to start adjusting for trends. There's some school districts that are on basically on life support systems that one claim will break their plans.
Right.
But your plan is still solid. It just needs to be adjusted to stay that way.
Yes.
If we turn to page number 14, it will give you a current breakdown of the monthly contributions from the employer, the district side, and the employee side, and it's broke down by employee only, employee in one town, employee in, three, but it doesn't have a premium yet. Employee, two employees and a family. Employee spouse, employee and family. This is your current plan.
So Roger, if I may, so what you have there are really the full detail of the rates and the funding and all those things. So it kind of supports the information you heard about. Definitely, we can go through it if you have questions, but this is really the schedule that were used to come up with the data that was presented before you. So these are exhibits. So if you don't mind, we can go to the last one, if that's okay? So the last one we have, and I'll let Mr. Gasa speak to it, we talked a little bit briefly about the self-funded versus fully funded. And so here is one model of what that would look like in terms of premium. And we wanted to show that to you because while the plan would be to go to fully funded, there would still be an employer contribution. It would not be the same employer contribution we're doing now. But Mr. Gasa can discuss with you the reason is why that once we offer it, Affordable Care Act said we can't take it away 100%, but it doesn't say you can't lower that contribution. So one of the savings he mentioned is adjusting our contribution lower, moving to a fully funded, and now it becomes a fully insured plan. So that's an illustration for you as a potential premiums on fully insured versus self-insured.
Is that page 15 or 16?
Page 17.
17.
Roger, you want to go through that real quick with them?
And here you're only talking about dental, self-funding
Yes, sir.
versus full-funded
Yes, sir.
dental.
It's, what's in, so we're paying $42 for employee family of 5, right? That's what the employee's paying.
That's what.
And under the high plan, same would be $69, so you're basically increasing, 18. That's about the market, right? I mean, we're gonna be what the market's paying.
That is the market, that
That's the
actually,
market.
it's still in the market value.
Yeah, absolutely. For that family of that size, yep.
And that was Mr.
Now, these
Haas's
are
point.
just illustrations, these are the current rates, but by the time we implement ours, there may be an adjustment, so maybe it's slightly higher, or may remain the same.
This is for 1920, right?
This is very
1920.
If I may, Mr. Alvaro, we need to get out of the dental administration business.
I agree. It's a good plan.
And unless you all have more questions, Mr. Garza, you want to kind of close it out for us?
Sure. The whole purpose here is to try to attempt to get our plan in compliance with what it's actually expending. I've said it before, your high plan is a plan that the district is funding almost at 100% of cost. And it doesn't matter how much more money you deposit to it, it's just impossible to keep up, you can't afford it. However, some of the changes that we're making today, or we're proposing today, is to try to keep up with the pace of that cost. And the tier disclosure that we have, although there's gonna be some adjustments for those tiers, but those are the tiers that are incurring the majority of the entire cost for your employees that are attempting to participate. And we feel if you look at page number 15 and 16 for
We're so close.
inflation and cost.
The nickel ran out, Roger.
Awesome.
We concur.
So we're good?
Thank you, Roger.
Thanks, Roger.
So my last closing
Thank
comment
you.
is,
Good. He thanked us. We're
my
good.
closing comment is that,
So I apologize for not addressing you correctly in the opening. I saw one split picture. So I apologize to members and to Mr. Vela and the superintendent.
It's all right.
Thank you, Roger. My last comment was gonna be just to let you know that our plans for administration to bring your recommendation, as I said, for 18-19, not all the items listed here, there's 10 items, required board action, some of them are administratively we're already doing, and we're continue doing. What we will bring with, as a recommendation would be item 1, which would be the premiums. Item 3, which to formally approve the closed formulary. Item number 10, the ER co-pays. The other items on here, as I said, administratively, we're already doing or can proceed or without necessarily bringing it to you. They're not board action type items.
Awesome.
Good work.
You bring it in this coming Monday?
Yes, sir.
Tuesday.
Yes, sir.
Tuesday.
Yes, sir.
Good job, Mr. Silva. Appreciate that, Mr. Miller.
Thank you, Roger, for your help.
Thank you all very much. Y'all have a great evening.
Any other questions or comments from the board? Hearing none. Is there a motion to adjourn?
So, second.
It's been moved and seconded that we adjourn. All those in favor signify by saying aye.
Aye.
Opposed, same sign. At 7:21, we are adjourned. Thank you, guys.